I'm Dr. Anthony Kaveh, and so many patients are concerned about emergence delirium or waking up combative, kicking and screaming when they're on the operating table, like the one that you see here. And they often don't remember what happens, but they might have nightmares. For the couple of days after surgery, they might feel uneasy, or they might, quite frankly, be embarrassed if someone shares with them what they did when they were waking up, even if they don't remember it. So that erratic kicking, screaming, cussing, you name it, emergence delirium. And I want to share 5 tips in this live unscripted stream for you so that you can be more empowered if you ever need surgery. And you'll see these same tips are actually applicable to any time in life when we are in survival mode and feel threatened. Because the emergence delirium that happens in patients is most pronounced when we are in survival mode and are threatened in survival mode. There are many reasons for the emergence delirium. It can be from medications, from pain, from vital sign abnormalities, but oftentimes in otherwise healthy patients, if they are in survival mode, like from the fear of being in the operating room, maybe PTSD in the medical setting that's unlocked, that can be further exacerbated from the real physical threat of being under the influence of anesthetics or having been cut open from surgery. So the tips all surround the concepts of confidence, control, and certainty. Those are the 3 C's that I share with my patients regularly: confidence, control, and certainty. And each of these 5 tips relates back to those. And as a reminder, please leave your questions for the end so we can answer them. We'll go through as many as we can in the time that we have. But number 1 is, how can you gain control to come out of survival mode in the operating room? And it's so easy. Hold your own mask before you fall asleep. Got it? But number 1, gain control in the last few moments when you're on the operating room table before you lose consciousness. And holding your own mask and controlling your breathing to take those big deep breaths to pre-oxygenate yourself. That is connected to the ventilator here. At 100% oxygen, take big deep breaths and hold your own mask and breathe on your terms. You have complete control over your physiology in most elective surgeries. And don't let somebody else mash that mask over your face, getting in your eyes, squishing your nose, being uncomfortable, because your last few moments of control might help you wake up with greater sense of control, and that is the antidote to survival mode. Because when you're in survival mode, you typically don't have control. You don't have confidence. You don't have certainty. And actually, like Mia is saying, listening to music and playing DJ for yourself in the operating room can also give you a greater sense of control. And I always recommend patients to ask for that. Number 2, another way to gain control in those precious few minutes before going under is to ask your doctor for 2 things. 1, hold this hose here. What is this hose? This is a warming device. This one is by 3M. I'm not getting paid by 3M, but it's a commonly used model in operating rooms. It's called a bear hugger. It blows warm air on you. It's actually very comfortable in the otherwise freezing cold operating room. When you hold that hose yourself to somewhere on your body that's chilly, so you can literally hold the hose with one hand and hold the mask with the other, you are now in control of your body even more, your body temperature, which we know gets dysregulated when you're under anesthesia. And similarly, as you are breathing, you can ask your anesthesiologist to place the pulse oximeter on your finger and raise the volume of it so you can hear your heartbeat. In other videos, I've showed how much I've controlled my heartbeat. And when patients are in the zone and are breathing and synchronizing their heart rate variability, it gives them even more control in those precious few minutes before relinquishing control to their anesthesiologist and surgeon. Number 2, control your temperature and control your heart rate. The vital signs that inherently get disrupted when you're connected to the ventilator when you're under general anesthesia. By the way, if you appreciate me sharing these tips, if you could hit that like button to share, to support what I'm doing, even after a long day in the operating room, coming on to answer your questions, and also share what you've learned with others, especially if they're having surgery or if they've ever struggled with living in survival mode, either from past experiences or PTSD, depression, or anxiety. You have more power over your health than you've ever been told, and that's what I hope you can take away from these live streams. Also, you can consider joining our exclusive access channel where we have private Zoom meetups. We're going to have one tonight, and there you can ask more personalized questions, and that also is a fantastic way to learn more and to support me doing more of these videos for you. Let's move on to number 4. And that is about the medications that your anesthesiologist gives you before you fall asleep. So, like I said, confidence, control, and certainty. These are the antidotes to pulling ourselves out of survival mode. Imagine a little fish that's being chased by a shark. That little fish does not go in a linear path. It goes up, down, left, right. It's all erratic. Just like when patients are waking up all erratically acting. Maybe they have erratic dreams for the next couple of days. Gaining confidence, certainty, and control before you go under anesthesia are the ways to be able to exit control mode, especially when you're threatened by the risk of surgery and going unconscious under anesthesia. And talking to your anesthesiologist about the medications is powerful because, one, it gives you more confidence in knowing what is going to happen to your body. And number 2, if you share a history of emergence delirium, if you share histories of medical PTSD, if you share what your concerns are, they can tailor their medications to help reduce the risk of emergence delirium, giving you more confidence in your anesthesia plan. I do want to thank Chantal Vanderham for that super thanks. So kind of you. I appreciate that so much. And just as an example of what I give as an anesthesiologist in patients who are prone to emergence delirium, maybe from combat PTSD or having had bad experiences around doctors, maybe seeing family members be treated less than ideal, or maybe in ways that were still hurtful. No matter how much the doctors try to do their best, I like to use medications like Precedex, maybe a little bit of benzodiazepine like midazolam at the end. There are many ways that anesthesiologists can tailor the medications specifically, and sometimes patients that like to be in control and know what's going to happen will find a way to feel more confident before they fall asleep to help bring them out of survival mode in those important moments. Joe McEwen, thank you so much for that super thanks, very kind. Let's go on to number 5, and that's talking to your surgeon specifically about the plan. Now, in other videos, you've heard me share about the importance of asking your doctors about their plan, because doctors are paid to come up with plans for patients, and medical gaslighting can often be countered by asking doctors specifically about what their plan is, so that we don't feel as helpless or as confused or as uncertain or as unconfident in our medical plan. So just like in the medical gaslighting setting, how that robs us of certainty and confidence, the same before surgery by speaking with your surgeon and specifically asking them about the plan can be so powerful. One small example is, where are your pain medications going to be after you wake up? Because time and time again, patients wake up, before they ever fall asleep, they're like, wait a minute, I didn't pick up my pain meds. I'm going to go home after surgery. If it's a day surgery, which so many surgeries are these days, I'm going to go home in pain. And then the last thing they're thinking before they fall asleep is concern and worry about where their pain prescription is going to be picked up. That's not the last thing you want to be thinking before you fall asleep. You want to be, like I said, embracing thoughts that give you control, confidence, and certainty, not confusion, uncertainty, and fear of pain after you wake up, especially if it can be prevented so easily by confirming your plan with your surgeon before the morning of surgery, if at all possible. You also want to know your plan for PT. What can you eat after? Who's going to be cooking for you after? What kind of physical activity can you do after? How many days off from work? So many patients come into surgery asking these basic questions, and as basic as they sound, do rob us from focus on ourselves, the self-compassion, on our inner healing, and instead we're worried about all sorts of logistics that are easy to answer and should be answered before, to give you confidence in why you're in this room in the first place before you fall asleep and give up all control under general anesthesia. Now, you'll appreciate that all of these are going to this concept of tolerance of ambiguity, or tolerance of uncertainty. And it's not by accident that so much of our inner healing is uncovered when we have a strong sense of cognitive flexibility. This is what I work on with my patients in my ketamine and my NAD clinic in San Francisco, which is fascinating in the setting of the operating room, because ketamine is used as an anesthetic in surgery. And in fact, most of the medications that come out of this ventilator behind me, everything from laughing gas to the other anesthesia gases, even propofol to an extent, can, in some settings, be used to facilitate greater senses of cognitive flexibility. Just like when that mighty oak tree snaps in the storm, yet the willow reed is flexible, right? It's resilient, it's supple, it can sway back and forth and not snap. That is the resilience that I want you to have when you are threatened in survival mode, to minimize the chance of you being like the little minnow being chased by the shark, erratically going up, down, left, right, whether on the operating room table, or it may be in your dreams, or in your thought processes when you're traumatized and people are saying, oh, you're so inattentive, you have ADHD. Well, maybe you do have ADHD, but maybe it's also a result of being in survival mode and being threatened and being like that little minnow in the ocean, erratically going as fast as it can away from its threat. Cognitive flexibility helps us, in times of real threat, be able to control the variables that we can and accept a level of ambiguity for factors that we cannot control. And it's no mistake that meditation can do that, and psychedelics, when used medically and properly and ethically, can do that, including some of which are anesthetics, and that's actually how some patients come out with new insights after surgery and anesthesia, which might be so counterintuitive because you're thinking they've given up all sense of control and they are threatened and possibly in survival mode, yet they come out more resilient than before they fell asleep, attesting to how much power you have over your health, which is more than you've probably ever been told. If you appreciate me coming on once again, do please hit that like button and share what you've learned with others to empower your loved ones. And once again, you can always join our private Zoom Hangouts by joining the Medical Secrets exclusive access. We're meeting tonight, and let's answer some of your questions now, starting with what's the first question that we have? Vaping. CyberDoc mentions vaping. Now, I don't know what you're vaping, but vaping before surgery is not recommended for many reasons, including airway irritation, as well as the effects of the substances that are being vaped, nicotine, etc. Donna is getting a pain block for the next shoulder surgery. I'm wishing you the best. Nitrous oxide, says Lone Trucker, used to play with that. Well, nitrous oxide used medically actually has NMDA receptor antagonism activity similar to ketamine. It is not regularly used for addressing mental health, though one wonders if there is not a potential to do so. Just not something that's as easy to transport as ketamine, for example. Very good point. Silly question, says Jai Peace. If a patient is depressed, will you consume laughing gas as a doctor to lighten their mood? Well, as a doctor, I will not consume laughing gas. Might I give laughing gas to the patient? I actually don't use much laughing gas because of its side effects, and it's an incredibly potent greenhouse gas. And there are many alternatives that are safer to give often and less, if you will, polluting to the environment. And if there's any pregnant women in the operating room, they don't want to be exposed to laughing gas. So I usually don't use it. There are other ways to help calm depressed patients and to empower them to gain resilience and confidence before they fall asleep, to maximize their chance of not waking up combative or with long-term side effects. Another thank you to Chantel Vanderham, very kind of you. Why does propofol burn, asks Rebecca. It is due to what it is suspended in. That combination of soybean oil to help stabilize propofol does cause that irritation. You can tell your anesthesiologist, and often we use lidocaine to help minimize that burning. We don't use large mallets, CyberDoc. Storm and Norman, good to see you. But it is quite funny, Cyber, I agree with Allison on that. Big Guy's wifey, you're very, very welcome. Just had a surgery, says Barbara. Doctor told me he was going to inject in my IV. Don't remember having a mask. Well, perhaps you had sedation, in which case you didn't need a mask like this. I don't know without knowing more of what kind of surgery you had. But I'm kind of curious now. Let me know below if you know. Now, Suchita says, laughter helps. I was nervous, as all, so I kept everyone in pre-op in stitches. Everyone in the room stopped by, helped my nerves. I kept everyone in pre-op in stitches. I guess you were making jokes. That's awesome. Suchita, you nailed it. Humor is one of our best antidotes, at least for situational anxiety, sometimes for general anxiety. But the fact that you were able to entertain others certainly also gave them something to look forward to, and seeing you in the operating room as well, I'm sure, after pre-op. I love it. I love it. A lot of people are saying humor. Yeah, humor is a powerful form of medicine. Lotus, I recently had surgery and had no burning with the propofol at all, thankfully. Well, I'm so happy that you had such a positive experience, Lotus. I'm wishing you the best for your recovery. I'm curious as to how it's going. Why do doctors schedule colonoscopies and endoscopy procedure at the same time? I'm not clear why. Well, Carmela, it's often easier to get 2 procedures done at the same time because that way you're fasting only once instead of twice, and it's less anesthesia, so less anesthesia risk, less time off from work, typically more convenient, and it can be more cost effective as well. So that's why they like to do them together when possible. Is twilight anesthesia really a thing? Well, twilight anesthesia is simply a reflection of the dose of anesthesia used. Very good question. And V. Miller, I appreciate the like comment there. Sulfolette, I got a nerve block before wrist surgery and inhaled something that caused inhalational pneumonia. Did the nerve block possibly make my cough reflex or diaphragm not get rid of what I inhaled? Sulfolette, I'm so sorry to hear about this unusual side effect and complication. I don't know what the inhaled agent was. I don't really know the rest of the specifics. I'm not aware of something that a nerve block, especially for a wrist, would do to increase that risk. Now, supraclavicular blocks do increase or do have a risk of diaphragmatic paralysis, but that typically should not interfere with the cough reflex. Perhaps something was aspirated, and that could have led to an aspiration pneumonia or pneumonitis. I'm really sorry that you had that experience. It does emphasize that even the safest, most elective surgeries do have risks, which is why if one can heal without the need for surgery, there are so many benefits there to avoid those risks. Inner healing potential, once again, so few side effects compared to anything else in Western medicine. I had gallbladder removal, says someone whose name is in Hebrew and I cannot read, and got the anesthesia through the IV without a mask. How can that be? If you just had an infusion of propofol or infusion of ketamine or a combination of the two, you may have had what's called a TIVA or a total intravenous anesthetic. You probably did have a breathing tube though after you fell asleep, you just don't remember it. And Lucy Lou says, I'm having thoracic surgery, I'm terrified. Lucy, I hope everyone here sends you positive energy, if you will, and helps give you confidence to ask the questions of your care team to build certainty, confidence, and hopefully help you feel more in control leading up to your thoracic surgery. All right, what other questions do we have? Oh, and a super thanks. Well, thank you, Donna. That's very kind of you. D. Smith, thank you for sharing with others. Let's do 2 more questions. I woke up and told my surgeon he was hot, says Donna. Well, everyone in the operating room has seen that happen a couple of times, so you are not alone. Alcohol rub, says CyberDoc. No, we don't use an alcohol rub beyond alcohol prep pads for skin, for example, before we poke needles like for IVs or for shots. What caused the burning feeling? Jody, good question. It was a propofol. Moss staff has bad needleophobia. I have an LP scheduled on Tuesday under GA, general anesthesia. I'm having so much anxiety, trouble eating and sleeping. Gosh, well, Moss staff, I'm so sorry that that you need to have this procedure and that you're having all this anxiety. I have several videos on anxiety before any type of procedure, whether it be full-on surgery or something like a lumbar puncture or LP. My biggest tips before any needle goes in are, as you know, or maybe you don't know, but I like to cough. I ask patients to give me a big cough on 3. That's when I numb their skin. I use a 30 gauge needle with lidocaine, sometimes with bicarb mixed in to minimize the burning of that initial poke, and it works wonders. In fact, I do it for myself. If I'm ever getting blood drawn or if I'm getting a shot for something, I always tell them, please give me a countdown so I can start coughing. And it works so powerfully to focus on the muscles in your throat to, if you will, distract from the muscle tension that you have in the injection site that would probably lead to a higher chance of discomfort with the needle poke. Very good question. And Carmilla Devine, thank you once again for that kind super thanks. Lotus says that brain fog is still there 2 weeks post-op, something I underestimated. Well, I'm so happy that you had that calmness and composure and felt prepared. For brain fog, do let your anesthesiologist or surgeon know if you have the opportunity so they can monitor to make sure that it does uplift. There are certainly some nutritional recommendations that I've shared in other videos to help minimize that, but we can maybe have a whole topic on that one day as well. And last question, Nikki Tupoles. I use rubbing alcohol and water in freezer bag for ice pack. Nice, soft, and slushy, and cheap. Well, I love that. That's fantastic, Nikki. Wasn't quite a question, so let me answer Teresa's question. How common is post-op depression? We don't have good estimates on that because it depends on the baseline depression and so many variables that happen in the operating room. How much do you know your surgery team? How confident are you in your doctors? How certain are you that you even need the surgery? What type of surgery is it? So there's so many variables, but it is likely very underreported because who asks patients about their mood after surgery? In the Western medical model, we simply don't do that nearly as much as we should. I suspect one day we will, but this is why I always encourage my patients to optimize their mindsets as much as possible, even if it's with those 5 tricks I shared earlier. And actually, I'll end with Rebecca's question. I get a lot of ECTs, electroconvulsive therapies. Do they put something in your mouth? Sometimes yes, sometimes no. Depends on the other comorbidities. Sometimes the anesthesiologist typically is just bagging the patient, meaning that they are squeezing the bag like that, and there is a mask over the patient's mouth, and they are literally putting air in through the mouth, maybe with an oral airway, but typically intubation is not needed for ECT. It does depend, though, on the patient's morphology, if you will, how big their neck is, do they have sleep apnea, etc. Very good question. Once again, thank you so much, everyone, for your kind comments and empowering others in our live stream. I look forward to seeing some of you in tonight's Zoom, those of you who are part of the exclusive access, and seeing the rest of you on our next live stream. Until next time, remember that you have more power over your health than you've ever been told.